have to pay for that?
We pay water and gas.
Neat. So you could always heat the place.
Consider This, with host Carol Schrader, is supported in part by Better Business Equipment and by Nebraskans for Public Television. Consider This, a news and information program recorded on the campus of the University of Nebraska at Omaha. From the Fireside Lounge in the Milo Bale Student Center, here is your host, Carol Schrader.
Hello and welcome once again to the UNO campus. My guest today is a very, very busy man. Not only is he involved in research and the treatment of cancer patients at the University of Nebraska Medical Center, but he is also the Dean of the NU College of Medicine. Welcome, Dr. James Armitage.
Thank you, Carol.
Now, I look back, you were here a couple years ago when the Med Center and Clarkson were creating that thing now known as NHS, that we hear people, yes. I'm sure, not quite used to that. And we'll talk about how that all went from your various hats and your various perspectives. But you started the lymphoma program at the University of Nebraska Medical Center, what, 18 years ago now, 19 years ago?
Yes.
And you just reached pretty exciting landmark, although you reach landmarks that we probably don't hear about all the time, some real watershed moments in the program. But why don't you tell the folks what happened?
Well, the lymphoma program is a big project, and it involves studying the biology of these cancers and new treatments for the cancers, and one aspect is bone marrow transplantation to treat patients with lymphomas. And back in 1983, when we first started doing transplants at Nebraska, we chose to focus on applying that treatment to patients with lymphoma. And there are really very few other places in the world that have done that. And we've had all sorts of important contributions over the years that have come from that effort, but what you're talking about is recently just transplanting the 1,000th patient with lymphoma at our institution.
And 1,000 is a big number. I mean, we tend to sort of relish in numbers that end in lots of zeros, because that's how we sort of mark progress. But really, I mean, these are individual people with, even though they had non-Hodgkin's lymphoma, they come to you and, you look for good candidates and they hope to do well. But each patient is, you learn a little more, and you've actually kind of sort of pioneered some aspects of this particular kind of transplant, correct?
Yes, we try not, although we write papers about our experience, and you'd have a certain number of patients in a paper, would never try to think about patients as a number or a statistic. As you said, these are individuals.
That's right.
They become your friends. They're people we want to do well. And there's some wonderful stories about people having been in situations where they certainly would not survive, and with this new treatment being cured. Just wonderful, exciting stories.
Now, the bone marrow treatment itself was kind of, some cancers react to this and some don't. So first it was like, which cancers will work? But then you decided we don't have to transplant the whole marrow.
Right. There are a number of advances that have occurred, but I think the one that you're interested in was done to a great degree by Ann Kessinger at our institution now about 15 years ago, when we had the idea that perhaps you would not have to suck marrow out of the bones of the pelvis, but you could get the same cells from the blood. Now, it was very difficult at first to do that. With the advent of some new drugs that cause these stem cells to shift from the marrow to the blood, it's become easier. But the process is, you take a patient and you do a pheresis procedure where you take the blood out of their body, run it through a machine that works like a cream separator.
Kind of splits it into the different elements.
It really works like a cream separator.
Don't be alarmed by this. This is a live student center.
And we then you can take off the cells you want, and these stem cells are in the fraction with lymphocytes. You take them off, store them, and those cells then can repopulate bone marrow after the marrow would be injured by high doses of chemotherapy or radiotherapy that you would do to treat the cancer.
So it automatically wants to go back into the marrow. These
Right.
are the cells you pulled sort of out of the marrow.
These cells are smart enough to know where they're supposed to go.
They've already know their identity and
Right.
know where they belong. This whole area of cancer research, I mean, for years and years, I mean, Epley Cancer Institute on the campus, you're an oncologist, but cancer research is one of the biggest research areas in the whole country because there are many types of cancer. How important is it at the University of Nebraska Medical Center?
You're right about cancer research right now in our country being a major emphasis, and the reason is we're for the first time really beginning to understand the mechanisms that make cells cancer. And that gives you new opportunities to interrupt those and benefit patients, or maybe even prevent it. And UNMC is no exception to that. This is an important issue, and probably if you added up all the different people working in the area and all the funding for it, I would guess it would be the biggest single research area on our campus right now. It would certainly be, if not the biggest, close to that. And of course, we have an NCI designated and funded cancer center that was partly the Epley and partly other investigators in the clinics, that's headed by Ken Cowan, who we were so fortunate as to steal from the National Cancer Institute to Nebraska a couple of years ago.
Now, when you added the lead transplant center, I think the janitor is rolling something through. When you added the lead transplant center and the generous donations of people that made that possible in the lead center, or the lead foundation, what did that add to what you were trying to do for these patients? I mean, what element did that add?
The lead center is actually really important for a lot of reasons. On top of the lead center are 4 floors of research space. So we have scientists doing experiments that are providing the knowledge to allow us to develop new treatments.
In a very concentrated area as opposed to being all over campus.
Right.
And
Then we have the oncology team has their offices there. Below that is 4 floors of what we call patient apartments. And this is the end product of about 15 years of work where we believed that most patients that were hospitalized could just as well not be in the hospital if you had a more efficient way to care for them. And so these patient apartments are where a patient who is undergoing a bone marrow transplant lives with their relative. Then down below there is what we call a day hospital, but it's actually it's open 24 hours a day, 7
kind of
days
like
a week.
clinic open.
All the time. And that's where patients get their nursing. And so a patient undergoing a transplant isn't any longer admitted to the hospital in the usual sense. They can live in this facility. If they need to be seen in a clinic, the clinic's on level 3. This hospital, if you like, is on level 3, but they only go there when they actually need to be nursed. And the rest of the time they're on their own. It's very much, patients like this a lot.
I visited Andy Rowe, your 1,000th patient. He's from Kansas City area. And they have like a little living room that you walk into, and then there's a bedroom, and the caregiver, which could be a wife, or in Andy's case, wife, sometimes mother, sometimes, or a good friend, depending on the availability of family. It was kind of interesting because so much of the transplant, after the transplant, is just follow up and making sure that they don't get infection, and that, I mean, there's a lot more to it, but I mean, once you designate a candidate for transplant, you go through all the prep work and everything. It's just really good follow-up, isn't it?
Well,
so they don't need to be...
Well, they need good nursing. The secret to a bone marrow transplant is high-quality nursing. We have the best nurses in the world, nothing close.
Andy said that.
But you only need to be nursed a certain time of the day. And as you said, there's no operation. You don't cut somebody open and do something to do this. The cells are given intravenously, and they're taken out from the veins. And so, as you said, the care that they get needs to be very, very careful observation, and then administering blood transfusions or antibiotics as necessary to deal with problems until the new marrow has recovered and the patient's back to normal. And you only need the nurse part of the time.
Now, does this cut down on the cost?
Tremendously, yes.
To insurers, and I'm sure there are some individuals that have to, that aren't insured, but
Right.
mostly people are
Right.
insured. I know a lot of HMOs have contracts or some HMOs with the university,
Right.
considering them A, a center of excellence, and B, it's a price advantage for them.
It is true, doing it this way is something patients like better. Physicians have learned to adapt to the fact that the patient isn't laying there waiting for you, now come wherever you want. You have to meet them at a certain time. And it's a more economical way to provide care. If we're going to make this treatment available to everybody, we have to be sure people can afford it. And as you said, today in America, bone marrow transplants are almost all paid for on contracts with particular insurers or HMOs or other organizations that provide care for a large number of people. And we have contracts with very many of those because we're recognized as a center of excellence. We have really good results. And we can compete on being able to do this in a more economical way. There are actually some other advantages we have. We live in Nebraska. It's really a nice place. There are really nice people here. Patients like it when they're here. They like the way they're treated by not just the nurses and physicians, but other Nebraskans. And it's one of the reasons we get patients from all over our country to come here for this treatment.
When you started out with your first transplant, there was about a 50-50 chance of leaving the hospital after the process and then the recovery. Now it's...
When we started doing transplants for lymphomas, about, a little bit better than you said, but not much, about 1 in 3 people died related to the procedure. Now, partly that was because we just weren't as good at it as we are 16 years later. And actually, 19 years, 18 years later, a long time later.
Time flies.
That's right. So we're better at it. We've learned a lot about how to do this. Using the blood cells, for example, has made it less toxic than when we use marrow cells. We have better antibiotics. In many ways, we're more clever at doing it, but it's also very important that we've learned which patients are likely to benefit from it. And so from 1 in 3 dying related to the procedure, today it's less than 1 in 20 would die related to the procedure. That's too many, but it's actually a risk that's comparable to other aggressive cancer therapies.
Cancer is one of those things that strikes fear in the hearts of people. And do you personally, and people that are involved in your program must, they're all different personalities, they come from different places, that's what makes up a good team.
Mm-hmm.
But there has to be, knowing that you've been able to make strides, not only for the patients that have come through here, but in terms of the research and the publications that they've done to help other people and work in concert with other hospitals. There's got to be a lot of satisfaction in that.
Oh, I think our team, as you said, which is all different kinds of physicians, nurses, people that clean the rooms, the people that work in the pharmacy, all sorts of people. I'm leaving out people, but a huge group of people make a bone marrow transplant successful. It's not any individual person doing a single thing. And I believe all those people have real pride in this. We started out back in 1983 by all of us, from everybody, meeting and going over each patient. The program is so large now that different subsets do that. But
they don't feel it's impersonal.
I think people feel like they're part of this.
I will tell you that I walked through there and I set my recording equipment down because I was doing a story, and a janitor that was cleaning a room just glowed with friendliness and said, "I wouldn't leave that there, ma'am, in the hall." I mean, it was just, and the patients told me as I sort of walked through that everybody there makes them feel like they are part of, that the team is off for them. And so, I mean, you don't exaggerate, I think.
Oh, I don't think at all. Sometimes people have in the past felt like you ought to, as a physician or a nurse or another provider, you ought to keep some distance from the patient because if you become emotionally involved, that'll somehow cloud your judgment. And I think that's just unimaginable nonsense. These are people who are scared to death, going through something that puts their life at risk. They need, in addition to people who are smart and do things technically correct, they need a friend. And I hope that we provide them lots of friends when they do this. It's not at all unusual, for example, for our nurses, if things aren't going well, to take a family member home to eat, to cheer them up. Volunteers from the hospital do shopping for them. People really treat people like they'd like to be treated. I can't say how proud I am of all these folks.
You know, that would make a good segue to the fact that you are the dean of the College of Medicine. And I had a lot of doctors in my family. Most of them are old or passed away, but they were certainly from the old school. Not only distance, but there's doctors and then there's nurses and everything else. Kind of, you know, they were nice people, but it was just the way things were done. Medical.
When I first practiced medicine, you go to a ward, and the nurses might get up and give the physician their chair when you come to a nurse's station.
Doesn't happen now.
Doesn't happen now. No, if you ask one of those nurses you saw at the transplant center about Mr. Jones, they would answer, "My patient, Mr. Jones." And if a physician asked them to give them their chair, it would be at some risk that the physician would do that. I'm sorry.
But the point I was making is that there was a real pecking order based on that knowledge, or perceived knowledge, was the pecking order. And now, because everything is such a team, nurses play a different role. They don't just do bedpans. I mean, they're part of the But anyway, in educating doctors now, there have had to have been some major changes, not to mention whole other issues like ethics and you know, really reading a patient as opposed to just you know, filling out charts and prescribing. I mean, it's a different world. And how have we met this new world?
It's an interesting challenge, because at the same time, you and I would like to see physicians be human beings, to treat somebody like they care about them, to be the friends of their patients. At the same time, the amount of knowledge about science is expanding at a scary rate that people have to know if they're going to be the physician you want also. And so it's been a challenge to do that. I think we're doing it well, that we're getting incredibly bright people into medical school. We've changed the way we teach somewhat, so we do it involving them in things that relate to patient care earlier, and in more small group things where we make them think. I hope we emphasize that being a physician is not, you're not a penicillin salesman. You are somebody's caregiver. Your job is to have this physician-patient relationship, which isn't, as you said, like it maybe once was, ordering people around. It's helping people deal with their illness, and part of that's careful scientific care, and part of it is understanding that's a human being you're trying to treat and understanding their problems and trying to help them with more things than just giving them the right pill. Computers are not likely to replace physicians soon, I don't think.
I don't think I'd want a computer, because just when they were diagnosing what I needed, that funny rectangle with the red X that says you performed an illegal operation would come up, and then I would be doomed. Okay, let's talk about medical college and kind of where it ranks. I don't know how they rank them, but we've recently seen in the Omaha World Herald the series on the University of Nebraska at Lincoln, of which you're considered in some ways a
Part of the University of Nebraska.
You're part of the thing, but sometimes they lump the College of Medicine in when they rank universities that have medical schools attached to them. The issue raised in the article talked about mediocrity. Now, I'm not going to debate what the status of the UNL is, but how is the College of Medicine ranked?
There'll be all sorts of ways to rank.
And I'm
a medical
sure there
school.
are.
If you look at research funding, we're steadily climbing. Hal Moore has made a major commitment for us to do better research, to obtain more external research funding.
That's the chancellor.
Yes, the chancellor of the medical school, the chancellor of UNMC. And we're building a new research building in that regard. We're doing all sorts of exciting things and steadily increasing our funding and our ranking in that regard. As regards teaching, I guess you'd have to, it depends on what you wanted to count. We have tremendous students by any measure. They all pass boards. They do very well. We are one of the top schools in the United States for training the proportion of primary care physicians that we train. So we're doing what this state needs, I think, about providing physicians for the state. As regards specific clinical care, there are a number of programs. I think the lymphoma team would be that, I believe. The liver program and our organ transplantation programs, among others, are programs that anybody would say are at the very top level in the world. and patients from all over the world come to Omaha for care in those programs. So there are a lot of things you can be very proud about.
It's hard to separate the College of Medicine and Nursing from the whole research and clinical, from the med center, because you benefit from, it's a real synergistic operation. The actual education, I know a lot of it happens in the classroom or in the educational setting, but you can't separate that necessarily.
Well, no. When a physician reaches their third year of medical school, the training is actually done out on the wards. If we want to teach people to be excellent physicians, we need excellent physicians as teachers and role models. You couldn't get the best people in America if you don't have excellent research, so that you're not trying new therapies, pushing back knowledge. These things are very interrelated. You can't be good at just one.
When you talked about serving the state and family practice, there was a big push for, well, it's almost been more than 2 decades now, to really try to help restock, not in just terms of doctors, but physicians' assistants and other things, the rural areas of the state. You know, this show we talk generally about the metro and how, but this is just critical to the future of Nebraska. How are you doing in that regard?
You know, the people of Nebraska have a medical school to which they give a lot of money each year.
Yes.
For the purpose of teaching their children to be medical school physicians, School of Allied Health, medical technologists and radiology technologists and so forth, the nursing school, the pharmacy school. And I believe we take very seriously that responsibility. I think we're providing physicians to care for the people in our state, and I think half or better of the physicians in Nebraska are from our medical school. It's not just physicians, as you pointed out, though. The School of Allied Health is part of the medical school, and that's the place that would train medical technologists, people to work in radiology and radiation oncology and so forth, a variety of other disciplines. And we're actually having probably at least as big a challenge there to get bright young people to want to enter those professions so that we can provide those experts throughout the state to get patients good care. It doesn't matter how smart your physicians are. If there are no nurses and no lab techs and no so forth, they're not going to do a very good job.
Well, particularly in this day and age of teleconferencing, where you need good people in the field, so that, you know, if you're working, maybe we've got a doctor that is working in an area, or they need expertise from the medical center and can do it by phone or show x-rays by some sort of magical, mystical means that I don't understand, that the people on the other end really know what they're doing.
Well, there's 2 things you brought up. One is this issue of telemedicine, of providing some sort of expertise at a distance. That's a thing that I don't think our country's figured out exactly how to do yet, although we and others are involved in trying to do so. And we actually provide help that way, not just in Nebraska, but some countries and other parts of the world. Having people to do the tests or carry out the treatments that a physician would decide are necessary for that patient is absolutely necessary to be able to get somebody good care. And sometimes that's not appreciated as much, that a physician can't do their job without this team of people.
Now, I know a lot of the medical schools, as is this General University here at UNO, have an increasing number of foreign students. And I'm sure the College of Medicine does too. And I'm not asking you to comment on that per se, but you know, are we educating enough Nebraskans that are staying here? Are we using up those slots for foreign students? What service does that provide?
The medical school takes almost all Nebraskans for new slots in medical school. A few people from other states. It would be extremely unusual to have a medical student from another country. And partly that's because that's clearly our charge, to teach the children of this state to be physicians. That's one of the things the medical school is supposed to do.
Are those children of our state that are being physicians and those other things in the allied health field, are they staying here? How many are we losing?
We can take a certain number in residency slots each year.
And that's key to be able, I mean,
and that's the most important thing, yes, to keep people. That's the key thing. So we keep, I think, a fairly high proportion, people like living in Nebraska if they've had a chance to live here. But people will go other places too, both to train and to practice. But as I said, about half the physicians, maybe slightly more than that practice in our state are from this medical school. Foreign students are more likely to be in residency slots or in PhD programs than they would be in the medical school.
All right. Now, if the issue is what kind of college of medicine do we have, I'm not saying that UNL is mediocre, because I'm not going to get into that pot of words, but saying that there are mediocre schools and there are excellent schools, how does our College of Medicine and the related fields stack up?
As I said, it's not a simple answer. It depends on how you calculate.
You?
I think we're really good. I think there are a number of things we're as good as there is in this country.
And if you could have something happen tomorrow or in the next year or 2 years to make it most
better?
Excellent, what do we need first?
Right now, we need more research space so that we can recruit more scientists to do research, and that's in the works. We need to expand the hospital, and we're building a building in between the old university and old Clarkson Hospital to allow us to develop new clinical programs. We'll need to find new space for education, and there's a plan being developed to accomplish just that. So we need to have the facilities and infrastructure to continue to get better and better.
And you're getting a lot of outside help. I mean, the taxpayers, you're getting a lot of really wonderful people and foundations that are helping out. And are the taxpayers, do you feel they're still supportive?
I think that Nebraskans are unusually aware of the importance of education. And we have been blessed with governors and legislatures and people that vote in this state who obviously value it because they support the University of Nebraska, I think, generously. Now, we never get as much as we think we could use.
Of course.
But it would be hard to complain about the way the University of Nebraska has been treated.
Well, I have all these other questions I didn't get answered, but I think education is a big topic right now, and I want to thank you for coming. Dr. James Armitage, founder of the lymphoma program at UNMC and Dean of the College of Medicine at the University of Nebraska. Thanks for joining us. And I'd like to make a mention that if you're a Thursday night viewer, Dr. Armitage will be the last person you see on this show on Thursday night, because beginning February 3rd, no more Thursday, we move to Saturday at noon and Sunday at 2 o'clock, plus all the other times available on the Knowledge Network. And then, of course, on NETV2, you will see us at 11:30 on Friday nights and at 12:30 in the afternoon on Mondays. So just stay tuned, okay? Thanks so much for joining us on Consider This.
Consider This, with host Carol Schrader, is supported in part by Better Business Equipment and by Nebraskans for Public Television.
Beginning this February, your news and information program of choice, Consider This, can be seen twice as often. In the Omaha Metro, you can watch Consider This on KYNE-TV Saturdays at noon and Sunday afternoons at 2. Statewide on NETV2, you can see Consider This Friday nights at 11:30 and Monday afternoons at 12:30. More Consider This more often, more chances to be informed. Call us for a schedule.